Good morning, everybody, and welcome to the PQRS reporting for 2016 and preparing for MIPS in 2017 webinar. My name is Michael Saperstein. I'm a marketing manager with the SpectrumMedics team. Before we get started, I'd like to briefly turn the presentation over to Kelly Casey from MHA Ventures for a brief introduction.
Thank you, Michael. As Michael mentioned, thank you to everyone for attending this webinar today. I am Kelly Casey, the Director of Shared Services of MHA Ventures. MHA Ventures is the for-profit subsidiary of the Montana Hospital Association. Our mission is to provide business solutions for our membership, either through creating revenue streams, cost savings, or gains in efficiencies. We achieve this through one of our 4 programs that we offer our membership: endorsed services, partnership programs, group purchasing, or workforce services. One of the main programs that MHA Ventures offers is our endorsed services programs, where we actually go through a vetting process with companies and they gain our seal of approval and our endorsement. Currently, MHA Ventures endorses around 55 companies, companies ranging from consulting and outsourcing, equipment supplies, insurance and benefits management, or revenue cycle and expense management. SpectrumMedics is a healthcare analytics and healthcare IT company who specializes in helping hospitals transition to fee-for-value and risk-based models. SpectrumMedics is tentatively endorsed by MHA Ventures, and we look forward to our continued partnership with SpectrumMedics. With that, I will turn it back over to Michael, and he can take it from here.
Thank you, Kelly, and thanks for the opportunity to present. Before we begin, I'd just like to go over a few housekeeping items. At the end of the webinar, there'll be a brief Q&A session. Feel free to enter your questions in the webinar control panel anytime during the presentation, and we'll address the questions at that time. Additionally, there'll be 2 short breaks during the presentation for poll questions. Please take the time to answer them, as it helps us to refine our webinars and provide even more meaningful content in the future. Finally, at the end of the webinar, we'll send each attendee a follow-up email containing highlights from the presentation. Now I'd like to introduce the panelists today from the SpectrumMedics side. First will be Dr. Raj Lakhanpal, who is the founder and CEO of SpectrumMedics. He is also a member of the HIMSS Clinical Business Intelligence Committee. Prior to SpectrumMedics, he founded Health A to Z, an online health and wellness population management platform that assisted health plans and other clients in reducing their healthcare costs. He is currently a member of the Board of Trustees of the University of the Sciences in Philadelphia, as well as a fellow of the American College of Emergency Room Physicians and the Royal College of Physicians and Surgeons in the United Kingdom. We will also have Mark Bryant speaking today. He's the Director of Sales for SpectrumMedics. He's responsible for new business development and client relations. Formerly, he held similar roles with both Sun Microsystems and Iron Mountain. Next, a brief agenda. First, we'll detail the requirements and deadlines for 2016 PQRS reporting. Second, we'll go into understanding VBPM for 2016. Third, we'll talk about preparing for the transition to MIPS in 2017. And finally, we'll go a little into detail about the SpectrumMedics PQRS and MIPS solution. So without further delay, I'd like to turn this over to Dr. Lakhanpal.
Hello, good morning, everyone. It's a pleasure to present to you. My name is Raj Lakhanpal. As Mike had stated, we're going to start with, at least I'm going to start first with PQRS, talk about PQRS, and then move to VBPM and then MIPS. And then Mark Bryant, my colleague, will present our SpectrumMedics platform to you. PQRS, you have to report this year, and you have to report 9 measures across 3 domains. And the deadline for that is 3/31/2017. Unless you're reporting with ECQMs, when the deadline is end of February. and you need to report at least one cross-cutting measure. The cross-cutting measures are those that apply to multiple domains, to multiple specialties. For example, immunizations, influenza immunizations, a cross-cutting measure, and BMI calculation is another cross-cutting measure. And you have to report for the whole year, for the entire 2016 calendar year. So, if you haven't started yet, you need to plan right away. You need to execute right away, because as Mark will show you, it will take time for you to get all your ducks in a row. So, getting all the processes moving will take time. And Spectromedics has close to 170 measures that we report on. We are a registry, certified registry by CMS, as well as, in addition to that, we have 64 ECQMs that can come directly out of the EMR and 23 measure groups. And the concept of the measure group is that instead of reporting 9 measures across 3 domains, you can say, I will report the diabetes measure group, or I will report the cancer measure group, the oncology measure group. And then all the measures, for example, oncology measure group, that's the group measures that the oncologists need to report. So who must report for 2016? I think this must be common knowledge by now. I just want to reiterate that it's not just the physicians on the left, but it's all EPs. EPs are eligible professionals, and those are different practitioners as well, physician assistants, nurse practitioners, and the list, you see the entire list there, as well as therapists, physical therapists, occupational therapists, speech therapists. So the numbers, it is not, in the good old days, it was only just the physicians. Now it's the entire universe of EPs. Everybody that bills Part B Medicare separately, under a separate 10, needs to report for PQRS measures. Different options. You have on the left side is the individual EP reporting option. So you can report through a certified vendor. So report through ECQMs, as we say, report through certified EHR technology. You can report through a qualified PQRS registry, or you could report through a QCDR. The difference between QCDR and a PQRS registry is that in a QCDR, you can also report custom measures. On the other side, the group reporting options, if you have not reported yet, may be a good option. Well, it may not be a good option if you've not elected, but another option is a group reporting option, which again, you can report as an EC through a certified EHR technology, as a registry, as a QCDR, and as a CMS G Pro web interface too. If you're greater than 100 EPs, then you need to report on patient satisfaction measures too. And that's again via a CMS certified survey vendor. This is an interesting slide. I think it's an important slide, informative slide. So this is now I'm transitioning to VBPM. So if you see the first key reporting area that you control is PQRS measures. So PQRS reporting outcomes, CMS tracks, patient satisfaction, CMS tracks, and then the cost measures tracking is again by CMS, where CMS will track your claims and see how you're performing. So within VBPM, CMS will calculate a quality of care composite score as well as cost of care composite score, the one in the orange. This is a cost-neutral program to CMS. We're in the VBPM reporting phase right now. So this year and last year, VBPM kicked in last year. So we're in the VBPM reporting phase. As I mentioned, it's a budget-neutral program to CMS. And keep in mind, your PQRS measures as you report them. The cost of care, your institution should be getting a QRUR report twice a year, generally in the summer and in the in the winter months, or July and December time frame. You should look at the QRUR report. That gives you a good idea of how your organization is performing in terms of quality. So it's a budget neutral program. So the sure way of not getting any incentive is not to report your PQRS measures. In that case, you will have a downward adjustment of at least 2%. And depending on how you are with other measures, it could be up to 4%. If you report PQRS and your quality scores are good, your outcomes are good, your cost of care composite score is good, and if you're greater than, if you're less than 10 EPs, you could get a 2x or a 1x upward adjustment. There is no downward adjustment for less than 10 EPs. If you're greater than 10 EPs, you could have a 2x or a 4x upward adjustment, or a 2% or 4% penalty. So the total delta between an upward adjustment and a penalty is 8% if you're greater than 10 EPs. And the VPPM payment modifier timeline, this is, again, it recaps what I was talking about earlier. So we're in the 2016 reporting period. The penalties and the incentives apply to 2018. It's 2x or 4x or 2% or 4% on the negative side. And really, it applies to everybody. So this entire thing here is stating that it applies to physicians with single providers as well as those with, greater than 2 EPs as well. So PQRS reporting is becoming more important. It has become more important and will become more important as we go along, and I'll explain to you why. So I think as you develop a strategy for PQRS reporting, if you have one, as you enhance your strategy for PQRS reporting, do keep in mind that you should align it with VBPM and meaningful use requirements. Choose your measures carefully. There's a whole concept of readiness assessment that Mark will talk about, and what you need to do in that is you need to take into account the availability of data. So one is, do you have data available for the measures that you want to track? Secondly, very importantly, where are your EPs performing well? Because the outcomes will matter too. And then communication is the key. That's on the right side here. Earlier, when there was only a 1% incentive, the quality departments would take care of everything. Now, because the delta, as I mentioned, could be up to 8%, please involve your finance team in this. It'll make you stronger, and also involve the IT teams as well. We call it the clinical revenue cycle because the delta is so much. 8% going up, you'll see, to much higher numbers, that it really impacts the revenues of the organization, and hold regular status meetings. And start the process early. Can't emphasize that enough. If you really want to go on a performance improvement track as opposed to just a regulatory compliance track. Now transitioning to MIPS. So I talked of PQRS, VBPM, and now MIPS. MIPS is, MACRA is the rule, and MIPS is the program. And MIPS stands for Merit-Based Incentive Payment System. And it's still not approved yet. It's due for approval in November timeframe. But what MIPS does is it consolidates all the 3 programs, PQRS, VBPM, as well as meaningful use. So it consolidates into one program. Hopefully we'll start 2017, and the penalties or the incentives will apply to 2019. And the incentive in 2019, which starts in 2017, are the same as VBPM this year. 4% on the upside, 4% on the downside. But they go much higher by 2022. So 9% on the upside and 9% on the downside. So there is an 18% delta as you go advance to 2022. And 2022 is not that far. 2022 is actually 2020 reporting. So that's 3 years from now, or 3.5 years from now. Also keep in mind that because there is, it's again proposed to be a cost-neutral program, that there is a potential for 3x adjustment. So if organizations don't do well and there's a penalty, they're subject to penalties, the organizations that report and do well could have a 3x upward adjustment. So your 4% in 2019 could be 12%. And then here are the categories for MIPS. You have quality, first of all, and that's the good old PQRS. The number of measures may go down, but quality is one. Resource use, I talked about that for BBPM. You have the same resource here as well. Clinical practice improvement, this is based on how you perform. There's a milestones-driven, there'll be it's going to be based on milestones, improvement of your quality, and it's a survey-based program there. And it'll include HIE integration, it'll include movement to patient-centered medical home, those kind of things. And then advancing care information would be around meaningful use. And that'll create a composite MIPS score. And the weights will be quality is 50% next year, proposed to be 50%. Cost is proposed to be 10%. Clinical practice improvement, which is survey-based, milestone-driven, is 15%. And then MU, or advancing care information, is 25%. So this is the breakup for next year, but this will change, as you see here. So quality is 50% in 2017. It goes down to 45% in 2018, and then goes down to 30% in 2019. And cost jumps up from 10% weightage to 15%, and then 30% in 2019. The other two components remain the same. So as for next year, quality is important. This year, PQRS is very important. Next year, but the weightage of quality will go down, and the weightage of costs will go up. And as I mentioned earlier, the penalties or the delta would be plus minus 4% in 2019, which is 2017 reporting, going up to plus minus 9% by 2022, which is 2020 reporting. I think I'm done with my section. Thank you.
Thank you, Dr. Lockenthal. Now we'd like to take our first short break for a poll question. The first question is, what is your biggest challenge to PQRS reporting in 2016? And the choices are identifying appropriate PQRS measures to calculate, successfully extracting then validating data from EHRs, or the ability to track, compare, and improve measure performance. So we'll give everybody a second to vote, and we'll be right back. Okay, everybody, it looks like the number one choice is successfully extracting, then validating data from EHRs. Now I'd like to turn the presentation over to Mark Bryant.
Thank you, Mike, and thank you, Kelly and MHA Ventures, for allowing us to present today. Very much appreciate the opportunity, and good morning to all the attendees. For my part, I'm going to walk you through a little bit about who we are, how we can help with PQRS, and what our engagement process looks like for any of our client relationships. So first, our goal, our mission, is to help hospitals and health systems make the transition from fee-for-service to fee-for-value and other risk-based models. And we do that in three ways. The first is the ability to consolidate data from disparate systems. And to the first poll question, successfully extracting data for PQRS is an area that I'll spend some time on in some upcoming slides. The second portion is around our measurement framework and being able to report for all hospital and ambulatory programs. And for this, we'll spend a good deal on the PQRS side. And then the last piece of it is predictive modeling and visualization. That applies to both hospital initiatives, such as doing analytics for readmissions, value-based purchasing, HAC-HAI, length of stay, and also on the ambulatory side for population health. And that involves risk stratification, geomapping, hotspotting, and other areas that we can assist with improving your members, your population, and engaging with them. And if that's of interest, we can certainly speak to that at a later time. At the bottom of this slide is just a sampling of some of our select clients and relationships. The first is Haney Solutions, which is a division of the Hospital Association in New York. They've endorsed our PQRS solution to their member hospitals, which is about 200 plus member hospitals across New York. Through that relationship, we were fortunate enough to sign with Greater Hudson Valley Health System and also at Auburn Community Hospital in 2015 for PQRS reporting. We've also added some additional hospitals in New York this year to report on as well. In the middle, you'll see Mount Sinai and Staten Island. Both of those, we're working quite a bit in New York State on Medicaid reform. They have a program called Disrupt Delivery System Reform Incentive Payment Program. It's quite a mouthful, but the goal is to reform Medicaid to help reduce costs and to help their hospitals reduce admissions and avoidable admissions by 25% over 5 years. So we're providing them measures to maximize their incentives and also population health analytics so they can do patient engagement. And we also have a couple other select partners at the bottom. Quantros is distributing our ECQM platform. Oracle, we're integrating with their EHA system. And also you see to the left is Richmond University Medical Center, a hospital in New York as well, that we're doing hospital analytics for too. So this slide is going to describe our qualifications, our measure platform, and how we can assist with multiple programs. So the first step is understanding your data sources, and I have a couple slides on that upcoming, so I'm going to skip that for now. But once we have your data, we can layer our measure framework around it, which allows us to report for, on the hospital side, all 29 hospital electronic clinical quality measures to support hospital and patient quality reporting, meaningful use, the Joint Commission, HAC-HAI, value-based purchasing, and any other custom initiatives you might have within your health system. And on the ambulatory side, we're certified for all 64 ECQMs to support PQRS and meaningful use via ECQMs. We're also a qualified registry as well. We could support ACO measures. We could support HEDIS measures, whether that's patient-centered medical home, STAR measures, pay-for-performance measures. Disrupt, like I stated, the Medicaid reform, it's HEDIS measure-driven, so we built measures to support that. Any other custom initiatives that you might have as well. TCPI, I should mention that. That's not listed here. We're supporting that with for some of our clients as well. So speaking specifically to PQRS, for individual reporting, we could support the submission of all 64 ECQMs. We're also a qualified registry and have 169 measures to choose from. And for individual reporting, we can also support 23 measure groups as well. On the GPRO side, again, we could support ECQMs, all 64 measures, and we can support 169 measures for PQRS. Via qualified registry. As Roger stated earlier, the measure group just applies to individual reporting. And if you wish to see a list of our measures, they're on our website, but we can also distribute that to you separately as well. Happy to do so. So once you're able to get data, and that's obviously one of the challenges, as you had pointed out as well, use that data in multiple ways. And that's what we try to strive to help our clients, is not just look at one program, but how can you, once you wrap your arms around your clinical data, how can you use that to report in multiple areas? And so there's three key ways that we work with our clients first to get the right data. And that's what we call standard formats. and that could be a QRDA1, a CCDA, your billing data, which comes in 837p, so we can ingest that type of data in standard formats. We can also, if you can't give us a standard format from EHR or can't get access to your billing data, we can provide you with what we call our data specification file, which will understand which measures you're looking to report on, and we'll give you a file that says, please, these are the areas, the elements that we need, and you'll be able to populate that and provide us a flat file back. And the third piece is if those options were not available, we can also build a custom interface into your EHR to extract that data. So then once we have the data, we populate our enterprise data warehouse, we layer a measure framework around it. We'll then provide you performance improvement dashboards, and I'll show that to you in a second. And then we handle all the submission. So we can handle the submission to CMS to satisfy PQRS as for ECQMs. We can handle it as a qualified registry. We can support meaningful use. We can support and submit for ACO measures, TCPI as well, and other programs across the board. So our portal is completely customizable to our clients' needs. It's role-based, and as you'll see in a second, what the portal looks like. But the roles are based on a couple different areas. We could set up the roles as an executive look, and the executive would be at your health system, your hospital level, your provider group level, to look at performance from an aggregate, and then drill down into, in this case, into PQRS to the specific providers and measures that you're looking to track. We can offer an analyst role, and the analyst role complements the executive role, but the analyst looks at everything as an aggregate, drills down into the measures, and actually can get into the patient level details, the PHI, for the true performance improvement. Tied to the analyst role is what we call a submitter role. It could be the same role as an analyst, depending on how your organization wishes to set it up. And the submitter role would go in prior to the submission deadline. So in the case for PQRS, if you're submitting via qualified registry, prior to the March 2017 deadline, they would go in and select the measures that are performing the best, push a button, and I'll show that to you, that generates a report to us that we would submit off. But they'd also have access at any time afterwards to pull that report back for compliance and audit reasons. And then the last role is a provider role. And the provider you can set up as a provider portal where that doctor can go in and be able to see his or her patients from an aggregate and then drill down to see utilization, demographics, gaps in care. We could do scorecards. We can also do disease registries as well out of the provider role. So with that, I'm going to go over into the portal itself. I figured today, since we have a smaller group, it'd be a good point that we can actually show you the portal and some of the functionality. So again, it's based on user roles. So I'm going to click first as a health system executive. And when I go into this screen, this is going to show multiple programs. So if your health system, your hospital, was looking to track both inpatient programs and ambulatory programs, we can configure the portal to be able to have access to all programs that are important to your system. Everything is color-coded, and I'll show you what the color coding, how it works when we dive into PQRS, but it's based on benchmarks. We provide 2 benchmarks to our clients. They can choose what those benchmarks are prior to implementation. It could be a national average, a state average, an internal target. And so therefore then, green means you're outperforming both benchmarks, orange means you're underperforming one, and red means you're underperforming both. So as an executive, you can come in and easily see at a high level how you're performing against the programs you're looking to track. And that could be for HIQR, the Joint Commission, PQRS measures, which I'll show, Accountable Care Organization. If you're part of Medicaid reform, you would have that there as well. So let me dive into PQRS real quick. So if I'm looking at PQRS, it would be set up on how you registered. So if you registered individually, your portal will be set up that way for your tax identification number. If you registered as a group, it would default to the group perspective. But let me show you the individual because that has a little bit more detail up front. So we're looking at an individual reporting. You have your care domains across the top. and how your individual EPs as an aggregate are performing against those care domains. And then you'd have a list down below of each of your eligible professionals and how they're performing against each of the care domains. Again, color-coded to the benchmarks that you set up and their performance. So we picked a particular eligible professional, Dr. Austin, and we click on Dr. Austin. Dr. Austin's performance is across the top as an aggregate against the care domains. And then you'll see the measures that are attributed to Dr. Austin that she wishes to track for the year. And you'll see diabetes, hemoglobin A1C poor control. It's currently underperforming the target you've set, but it's outperforming the national average, thus it's in orange. The next measure, as you can see, is outperforming both targets, and then this measure is underperforming both levels. And then if we want to see the measure details, we can click on the measure, and this will give us the ability to tracking month over month for this measure. We can see from a high level what's driving performance, patient population, denominator, any exclusions and exceptions, who's qualified for the numerator. Again, the executive role does not have PHI, so the informaticist or the analyst role, when I show you that in a second, can dive into that. We can also set up some customization for you and show you compliance by each of your providers to this measure, again, benchmarked as well. And we can set up a KPI, in this case, compliance by age group. So you can see for this measure, for your tax identification number in this case, because that's what everything is tied to, how your providers are doing in each age group tied to this measure. Okay. So I'm going to go back out, and I'm going to go to, to the informaticist look. So if I log in as an informaticist, again, I'm going to be logged into the particular reporting methodology that you registered as. So if you registered individually via qualified registry, you'd come to that report. If you're managing multiple tax identification numbers and they register differently, you'd have the ability to toggle between this. If you're looking to track ECQMs for meaningful use, you'd have an option here, GPro as well. So let's look at it as a qualified registry, individual reporting. So you can toggle between your individual EPs up top. This is the summary page. So here are the measures that you're looking to track or that you've chosen to track. Denominator, performance met, performance not met, what's your performance rate. If you click on a measure, you'll get into the patient level details. So in this case, if we look down, we can see this patient, T. Lee, performance was met for this measure. For T. Jones, performance is not met. And then for patient F. Brown, data is missing. So this then goes back to how we got it, how we extracted the data. If we were just taking in billing data, from billing data we can populate the denominator, but we can't populate the numerator off of billing data. So we would need a G code, or some type of code. So if, let's say, the G code was missing, that's where you're getting this message that's missing. We can then get from you the G code in a spreadsheet or provide you smart web forms in order to enter that G code in order to make sure that patient will populate the numerator. If we are taking in clinical data, the difference here would say data was missing, and it would give you what type of data, whether it was a medication, a lab result, or such that was missing. So that would give you the opportunity to go back into the EHR and correct that if it was mapped incorrectly, if it was entered in a different spot, if it was just missing and you needed to find that information. And then the next time we took in the data, that particular patient would be updated. So I'll show you if you're reporting as a GPro, the only difference is you wouldn't have the toggling ability here. You would be reporting as an aggregate, that is individual professionals. If you're reporting as by measure groups for individual, we can set that up as well. And here's an example of a diabetes measure group. For this measure group, there's 6 measures. Here are how they're performing, and then you'd have the same functionality underneath it. And I'm going to go right back to the qualified registry for 1 second. That's the summary page. The submission page is here, and here's where you'd be able to go and check off the measures that are, if you're tracking more measures than the 9 across 3 domains, you'll be able to check off the ones that are performing the best, and then you'll be able to come down to the bottom and click Ready for Reporting. This would then generate a report to us that we would send off to CMS. As a qualified registry, if you're reporting ECQMs, we would send it off as via ECQMs as well for that. Okay. And then the last thing I want to show you, back out real quick, excuse my demo. We can also do a provider portal as well. In this case, we're showing gaps in care. So this is the ability to give a disease registry to your providers to have their own login. So they can come in this case, we're looking at John Smith, diabetes registry. Here's a list of his patients, their information, if they have any comorbidities, and then based on the PQRS measures, how are they currently performing on those measures? Did they give did they have a last eye exam? If not, be able to then use that information to work to engage that patient and get the flu shot taken care of. If there's any missing data, again, that could be a G code or it could be clinical data. We give that type of reporting here as well for you. So I just want to give you a quick sense of the portal. Happy to go into further details and other functionality in it separately, but hopefully that gives you a sense of what we can offer as performance improvement. And with that, I'm going to turn it back over to Mike for our last survey question. Mike?
Thank you, Mark. Once again, guys, we appreciate you answering the survey question. The next question we're going to bring up here is, what is your biggest concern with the upcoming change to MIPS? The choices are understanding the transition of multiple programs to one, the ability to prepare in time to begin measurement on January 1 of 2017, the ability to collect the data necessary to measure and report, or finding a partner to help with the transition. So we'll give you guys a couple seconds to answer, and we'll be right back. Okay, everybody, it looks like we have a clear winner here, and that's the ability to prepare in time to begin measurement on January 1st. Now, once again, I'd like to turn this back over to Mark Bryant.
Thanks, Mike. And so for my last portion of this presentation, I'm going to walk through our engagement process, and I will cover how we can help you prepare. But the first thing, again, is how do we get data to report for this year and beyond? And so for PQRS, there's three methodologies. It's looking at structured data. How can we access a QRDA or CCDA from your EHR? There's also intelligent chart abstraction using the billing data, then complementing that with some type of web forms or other type of uploads to get the G codes to populate the numerator. And then we can also do the non-standard formats such as an interface or other flat file ingestion in order to satisfy it and be able to calculate the measures for your providers. So back to your question on the ability to prepare in time. And one of the key things that we feel that we can offer as value is up front we do what we call a readiness assessment. And that applies to any program, whether that's PQRS, whether that's the hospital programs for HIQR, ACO programs, DISR programs. We understand what measures that you're looking to track, and we get a sample amount of data. We run it against those measures, and we provide you a report back up front that says, in the case of PQRS, for your group or for your individual providers, we say, all right, this is the list of measures that pertain to you. Can you first calculate and report on these measures? Do we have the right data to do that? And then second, if you can, are there any gaps in that data? Is there any data that's missing? Are there G codes missing? Is there any clinical data missing? Is there any workflow issues that you can start addressing? And that's provided back to you prior to going into implementation. So let me walk you through what that looks like. So we do the assessment. That's from kickoff to usually about 30 to 45 days, depending on how fast that we can get data from you. We then allow a period of remediation. So if there is data issues, we'll work with you to address that. At the same time, we start implementing, building out the portal, getting your team trained on the portal, getting access together, understanding what benchmarks you want to utilize. We then go live, and that going live would happen right in this period. That'll then give you time to prepare, to look at your measures on an ongoing basis, leading up to the submission period. And then we provide the ongoing managed support and services. And the way we see this, and as we transition, especially into MIPS, is not only looking at reporting what measures this year, but improving upon quality measures and building a story, building that long-term plan, and ongoing look by utilizing our portal at these measures so you continuously improve your quality. And throughout this, we provide support on the back end as well, from maintaining our portal to the ongoing data collection. We'll figure out how often that we can access data for your providers or for any program that you're looking to track. The portal will give you the data governance and the performance improvement aspect of it. We take care of all the submission for CMS, for PQRS, and for other programs as well. If there's any changes, and we all know there's changes, especially with CMS year over year, with the measures, we'll upgrade the measures. We'll notify you of any changes in the measures. If they require different data, we'll work with your team on an ongoing basis to make sure that we have the right data to support. Which then leads into the last piece of my presentation is transitioning into MIPS. And we know MIPS is a proposed rule. We don't know all the components that will be finalized yet, but our platform and our processes are scalable. We believe, from what we understand of it, we can support all aspects for quality with the measures that are the PQRS measures today, resource use with cost and utilization analytics. We can support reporting for PCMH and calculating milestone improvements, and we can also support the meaningful use aspect as well. So this is just a summary slide of our measures. We have 64 again ECQMs. If you choose to report electronically, we're also a qualified registry to support 169 measures. We can support multiple methods to reporting for PQRS. We can support your eligible professionals that are not within your EHR and getting data from them to calculate their measures. If you have multiple tax identification numbers, we can support that as well. And we'll give you a portal for that ongoing performance improvement and helping you create that strategy, getting ahead to prepare for MIPS as it comes next year. And as we go into the question and answer session, we did recently release with one of our clients, Greater Hudson Valley Health System, a case study on how they reported PQRS in 2015. We'd be happy to share that with you if you're interested. You can go to our website or you can contact us directly. You can contact Greg Brown, who is our senior sales executive that covers your region. He'd be happy to address your questions, give you the case study, and help you in any way possible. And with that, I'm going to turn it back over to Mike to administer our Q&A session, but I greatly appreciate your time and look forward to hopefully working with you. Mike?
Thank you, Mark. We had a couple of really great questions come in. To help us answer them, I'd like to also bring in and introduce Raj Ardeshna. He is a business analyst specializing in PQRS with Spectrumetics.
Hi, everyone.
So the first question that came in is, how does your solution help with improving data quality?
That's a really great question. I think the best way to answer that is going off of something Mark mentioned in the webinar. One of the biggest contributions that our process and our solution makes is the ability to have that initial readiness assessment. And by doing that, we're able to see not only gaps in specific data that you may have, whether or not certain data elements are being collected, but even once that data is being processed, whether or not we're getting the information for all of the eligible patients, whether or not the performance rates are, to be expected, or if there's room for improvement. And at that point, we're really able to make suggestions towards improving the quality, both at a workflow perspective, but also at a data perspective.
Thanks, Raj. Next. Once I select Spectrometics for 2016 PQRS reporting, when would we need to begin the process?
The easy answer would be as soon as possible. It's really important just to, understand what your capabilities are as soon as that time may be. Going through the readiness assessment, kind of like I mentioned before, not only gives you the chance to see whether or not your data is storing and collecting the elements that you need for reporting, but whether or not there is enough information to satisfy the reporting and to get the performance rates that your organization wants to strive towards. The sooner you start, the sooner that you can make any potential changes as the year continues before the reporting deadline.
Next, can you provide a few examples of measures that a hospital-based EP should report?
It really depends on the type of reporting that the hospital has chosen. That kind of requires a more in-depth or specific answer, but whether or not you're reporting at an individual GPRO option kind of makes the first distinction. If you're working as a GPRO at a hospital level, you really want to look at certain screening measures or broad measures that could be applicable to most of the physicians there. But again, it really does make a difference on whether you're looking at an individual GPRO option for that.
Okay, everyone, I think that just about wraps it up. I'd like to just thank all of our attendees for their time today, as well as MHA Ventures for giving us the opportunity to present. So I hope you all have a great day. Thanks.
Thank you. Bye-bye.